All right, so with that, we'll move on to our first panel on the first 30 days. I'll hand it over to the moderator, Kiran Jobin-Putra, who, aside from his role within IATA, has worked for MSF for 16 plus years, has a ton of experience in the humanitarian field, and has been doing a lot of consulting with the World Health Organization lately. So, Kiran, over to you.
Right, good morning, everyone. Thank you, Sylvia, for that introduction. And of course, thank you to our keynotes for such a great framing for the discussions of the next couple of days. So it's my privilege to open this first session of the symposium. I also want to say it's wonderful to see so many experts in this field from across disciplines and across organizations. And amongst them, many of you I count as my friends, so that's also nice on a social level to see everyone again. As Sylvia said, over the last 3 years, I've been working actually across departments in the World Health Organization with SLIM and also with colleagues in the World Health Emergency Program on strengthening integration of NCDs in all hazards preparedness and response, all hazards emergency preparedness and response. And the idea of this session, the first 30 days, actually came from the fact that we've had, as Slim mentioned, a number of regional workshops and a high-level workshop in Copenhagen on NCDs and emergencies. And the discussions tend to focus on the post-acute phase and protracted emergencies, because most emergencies are protracted. This is where the bulk of our work and our energy lies. But one of the things we realize is that those very first days before the humanitarian response plan is written, which is the sort of overarching document developed by the health cluster to which aligns the work of the implementing partners and also which channels funding to many of the implementing partners. So before that document is written, what is happening in those first days? Because people's needs don't wait for 30 days. And I think a condition such as diabetes, and if we look at type 1 diabetes, where abrupt cessation of treatment can be rapidly fatal, what is happening until the humanitarian mechanisms kick in, let's say. And I would say that even from the perspective of MSF, an organization which has substantial funding of its own and is able to respond early. If MSF does not have a footprint in that country, meaning if MSF was not already present in that country, it still takes weeks. We know that for an effective response to be established. So what happens in those first days? What we know is that people are resourceful. People have their own resources. They have coping strategies. There are social solidarity mechanisms. The mechanisms by which people manage to get care of some kind vary across contexts, but people find ways. But in some contexts, we know that the Federation of Red Cross and Red Crescent Societies has been critical in those first days. In some countries, we know that military, in some contexts, particularly natural disasters, military can play a key role in making sure people with diabetes have access to insulin and other medications. But I think what we feel there's much to learn from those different experiences across contexts, and I feel we don't always discuss those first 30 days. So that's why today we have a panel focused on this, and we're joined by 4 excellent speakers who bring very diverse experiences and perspectives on this challenge of those first days, and who can help us understand what has been learnt and what are the opportunities for strengthening diabetes care in this hyperacute phase of the emergency. So before I invite up our first speaker, can I just check, is Teresa online as well? Great, okay. So our first speaker, Mohammed Sayam, is a medical doctor from Gaza, Palestine. He's currently in London, today he's in Athens, but at these times he's in London pursuing an MSc degree in global healthcare management. He's a global diabetes advocate and educator, a young leader in diabetes at the International Diabetes Federation, and the MENA regional chapter lead at T1 International. And Mohammed's work, please come up to the stage, Mohammed, focuses on access to health and health delivery around non-communicable diseases, specifically diabetes in low and middle-income countries. And Mohammed, I'd like to invite you to speak freely about what your perspectives on this, but I would particularly be interested if you could touch on your experience with peer educators and people living with diabetes in Gaza, and the extent to which you feel that informal community networks are important to get supplies to people, and how we can support those networks better. Thank you.
Okay, good morning. Lovely. Before I start with what is it that people with diabetes would need, specifically during the acute phase of a crisis, I always like to start by painting a picture of how would it look like on the onset of a crisis for a person in general, and then for a person with diabetes, because whether that's a man-made crisis or a natural disaster, for example, if I'm living in my apartment a couple of years ago in Turkey and the earthquake has erupted, and what I would think about is leaving my house. It's not going to be going to my fridge, bringing my insulin, and then going out of my house, because every second would matter for those people when it comes to evacuation, whether that's an earthquake, a flood, bombardment, whatever is happening, whatever that type of conflict that is happening is. And of course, that's a lot of stress for anybody. But when it comes to people with diabetes, it's extra, because what we think about in such times, in such rare times, is stabilizing, is the moment itself. How can we stabilize the moment? And the moment we realize that this has passed, we'd start thinking about, oh, do I have enough insulin? Or do I have enough medications? Do I have enough supplies? And unfortunately, even if I have enough insulin for a couple of days or for a couple of weeks, I'd still be thinking about the supplies that I'd have, because I'm still in that state of a crisis. This is not just a story. It is the story of every single person living with diabetes who's experienced or is experiencing a crisis. And again, it starts immediately because it's about the response. And as we mentioned, we've been listening to multiple of the keynote speakers addressing that it takes time for international bodies whom are experienced in the field to react. And of course, it's going to take time for people with diabetes themselves to react. So what would a person with diabetes need during the first 30 days of a crisis? And I'd like to think of it as a chain. So I'd start with supplies, because regularly we think, oh, education is important and support is important, but I'll never be thinking about my education if I don't have the supplies that I need. So without my insulin, any form of education wouldn't be as efficient or as effective as anybody would advertise it, because I don't have that insulin that you're educating me how to use it. So it definitely starts with the supplies. And it is the answer that I've been receiving from, because what I usually do when it comes to the diabetes community, I look for answers and I ask people for their own perspectives. Because this would add up. It's not just my experience, because I'm Palestinian and I've been through this in Gaza in a conflict by itself, but people have been living their own experiences in natural disasters and earthquakes and floods in different parts of the world would also add up to the answers that I try to seek. So their answers, or the first answer that they would think of, would always be supplies, whether that's a natural disaster or a man-made disaster. And during the first 30 days, as we try to comprehend what's going on with the picture that I've painted, we focus on supplies. And for me, without supplies, specifically for people with type 1 diabetes or insulin-dependent diabetics, without supplies, complications arise. And with complications, we see a sharp drop in the quality of lives for those people, even in the very first days, because without insulin, a person with type 1 diabetes wouldn't last for days or for weeks. And this means that we're talking about simply death for those people. Supplies, it's not about, when it comes to supplies, it's not just about availability of those supplies. It's about what types of supplies are there. Because, for example, for Abdullah from Gaza, during the first 5 weeks of the current attacks, he had to switch between 5 different types of insulin. And for him, with the lack of access to internet, with the lack of access to healthcare providers, it was hard to switch between those different types of insulin. So we're talking about a whole change of how their quality of life is, how stress is affecting them, how food isn't available, how they can't store their insulin in crises, and that's a whole different issue for people with diabetes. But then we're talking about this constant change of the types of medications that they are using. So I think we would all agree that it always starts with the supplies, with the types of the supplies that are available, with the equity in distributing those supplies, how the supply chain is working on for those people. Do they still need to go to a healthcare clinic or to the healthcare providers despite this process not being safe? Or can those supplies be delivered to them? What would be the best? And again, this would be the first thought for a person living with diabetes. And if I have got the supplies, I'd start thinking about the second part of this chain, which would be, in this stage, education. Because if I'd have to change, as we've mentioned about the story of Abdullah, if I'd have to change between different types of insulin, I need to know how to switch between different types of insulin. I need to know if my whole life is changing, what does this change, or how does this change affect my life with diabetes? I need to know about the food that I'm getting from international donors, for example, in times of crisis. How does it affect my diabetes? And of course, this is a lot. And we've been discussing this yesterday. Probably me and Felipe yesterday. We've been discussing this and saying, maybe if for example, healthcare providers are delivering supplies, maybe they can just write a simple note for people with diabetes on how can they use those supplies. Because again, in crises, maybe healthcare providers wouldn't have the time to, wouldn't have the time to actually educate people with diabetes about how to move on with their life. Or how can they manage the condition during such circumstances. So yes, education comes in different ways, whether that's peer support education, whether that's education from healthcare providers, but it's definitely a second point that comes on after supplies. A few thoughtful answers that I had from multiple people with diabetes were, Huban from Pakistan said community support. People with diabetes would need their community to support them because they feel for each other, specifically in times of dire need. And feeling for each other would include educating each other, sharing information about management, about availability of resources, about locations on where can you get those resources, and probably sharing surpluses of supplies. Because if I've got extra insulin, I can share my insulin because I feel for that person with diabetes, or my friend who's living with diabetes, and I give them some of my insulin to ensure that we both are surviving. Now, Wasim, who's currently in Gaza, he's a healthcare professional with type 1 diabetes, and he put some emphasis on support as well, but from a different perspective. So people with diabetes would need support from their healthcare providers, from their diabetes team. And he said that this support could be in educating and guiding people with diabetes and their caregivers through the obstacles that they face, especially when it comes to the scarcity of resources, how to, for example, recognize any of their acute complications, what symptoms are they having. Specifically, again, when we talk about supplies, we're also talking about test strips, or we're talking about diagnostics, and in such circumstances, people with diabetes don't really test their blood glucose levels, and they tend not to find enough test strips to test their blood glucose levels. So how to deal with that? What symptoms are hypersymptoms? What symptoms are low symptoms? How can you deal with them? How can a caregiver or the family of that person with diabetes react immediately to that? That's definitely important, and that comes in the role of healthcare providers and the community support as well. Lastly, Banu from Turkey said that people living with diabetes would need better and more efficient communication pathways. And probably it lies within kind of the supplies sector here, within the support sector here. And this comes, again, community and healthcare-wise, because she said this would have definitely saved a lot of lives for people living with diabetes during the earthquake if we'd had more efficient communication. Now, on my side, yes, we've mentioned that how this whole chain works. But for me, I believe that people living with diabetes, to make sure that what we've mentioned is secured, what they need, or what they require is an efficient, solid health system. It's not just a healthcare system. The whole healthcare system needs to be efficient, a system that is able to serve their needs during crises, that is solid, well-built, and can adapt to crises as quick as possible, a system that is prepared to react to disasters. Especially, we've seen that in a lot of areas across the world, whether that's a natural disaster or a man-made disaster, it comes more frequently in such system. It could be a conflict zone. Yes, we can see peace for example, in conflicts, we could see peace for a few months or for a few years, and then crises erupt again. Some areas in the world are more susceptible to natural disasters than others. So we need a system that is very well prepared to react immediately, and probably to involve people with diabetes themselves, and how can we as healthcare providers, or as this is in a different way, because this is in crises, it's not a simple problem. Let's do a simple solution. It's a complex problem, so we need a complex solution that, again, values those synergies. It's a non-linear solution. It's not about simple math, 1 + 1 = 2, and we can immediately do it. It's about how can we find a non-linear way to involve everybody, to value the synergies that we can all provide for people with diabetes, for them to feel that they are involved, that they are meaningfully engaged in how this is happening, that their decisions or that their thoughts are being taken into consideration, so they could hopefully help how healthcare systems are being shaped even after those 30 days to ensure that their lives and their quality of lives with diabetes are on the rise to the positive side. Thank you.
Thank you very much, Mohammed. I think we'll come back to questions afterwards, I think, just in the interest of time. But yes, yeah, great, if you can have a seat up there. But I think that frames the session very well. I think the clear reminder there from Mohammed that the reality is in those first days there won't be the humanitarian actors on the ground, and the importance of building resilience of health systems, of fostering community networks, and of helping people with diabetes develop their capacity to manage through these periods of disruption is paramount in these first days. We're going to move on to our second speaker now. So Dr. Akihiro Seita, the Director of Health for UNRWA, UN Relief and Works Agency for Palestine refugees in the Near East, who is responsible for overall primary healthcare provision for 6 million Palestinian refugees in Gaza, Jordan, Lebanon, Syria, and the West Bank, including East Jerusalem. Dr. Seita has been responsible for overseeing treatment for 300,000 people with diabetes, hypertension, including 100,000 in Gaza. And I think this is an ongoing challenge at present. I think, Dr. Seita, please come up and share your experiences. And I think slides. I think the slides should come up automatically. I would just say that. Well, no, yeah, please, yeah. I just say that I'm sure you're going to touch on this, but the chronic insecurity with frequent escalations, even prior to the current war that has been experienced in Gaza, I guess must give you a deep perspective on the sort of measures that you can be put in place, or that you have put in place, to minimize the impact of these disruptions for people living with diabetes. And I'd be grateful if you could say a word to that.
Thank you very much. Yes.
Okay, and I think you.
I hope.
Oops.
Okay.
That's
good.
it.
And then
So you just click the green button.
next. Okay, thank you very much. My name is Seita, and the head of UNRWA, which is very popular nowadays with different reasons. And then that I'm going to talk something is very difficult to talk because the situation continues. Just communicated with Dr. Zuhair, who is attending this. There's a heavy bombardment in Rafah ongoing. And so that's very difficult. But nevertheless, before the war, before the 7th of October, this is a photo in Gaza. The 3 kids, I went to Japan on that time before. It's 60,000 people with diabetes and 22 clinics, 1,000 great staff, family medicine approach, electronic medical records in place, all the health centers, and then the WHO essential medicine list. Good. And the 7th of October was a big shock. I was in Japan, I couldn't believe. And everybody in Gaza couldn't believe what's happened. And it's happened all of a sudden. The 3 kids who was with me in Japan still couldn't go back to Gaza. They are still in Amman, and they going to the schools in Amman. And because of security concern, that after 1 week of the start of the hostility, that all the UN agencies, including us, went to south to continue to provide the services. That's a major consequences, one of which is that we lost the central warehouse of medicines. So we lost the entire stock of the medicines. That's a major. My colleague Shada will talk later. And of course, the patient care is a major problem. And these are the number of health centers functioning before the 7th of October 22. Now 15, one day after 15, 11, 8, and 6, and 6. So within the week, number of health centers halved, become quarter. That's a major concern. So what we did, so this is Rafah. I was there last month, shelters, houses, tents everywhere in Rafah. There's 300,000 people, now 1.2 million people, and this is the famous Mawas area, which you may have heard from the news. It's tents everywhere. So then the current incursion continues. I honestly don't know where they go, and the people don't know where to go. That's the reality in Gaza. And then so back to the health responses, the first thing that we did a systems approach, because as mentioned that this is not the first hostility, but it's a major one, but so they prepare when it happens. So one is to maintain the increase the health centers. It reduced to 6, and they went to 9. And the shelter started open, and they went to the 92 at the end of the October. So we started providing a very basic care. And the additional staff, they recruited 300 temporary staff. And the medicine is a major challenge that I'm not going to talk in detail. It's okay. And then the number of patients coming to the health center every day, before the war it was 15,000, and they drastically reduced the minimum, and they continue to increase. So end of October somehow caught up the pre-7th October level of 15,000. So that's somehow great progress towards that how we can respond to this. But nevertheless, and for the diabetes, back to our main diabetes is a priority in Mohammed. If you know the humanitarian setting, we always define what is the program criticality 1, 2. And I don't know if it makes you happy, but education is not the PC1. So they are not happy people in this case, because there's no school available in Gaza, because all used as shelters. But nevertheless, so diabetes priority because of heavy burden, and so that all the health centers, they provide the services and the medicine, whatever they have it. It's a flexible access, which means that whenever they go, they can get the medicine, because it is still connected to electronic medical records. And wherever they go, they can get whatever they could. And it's good news and bad news. Good news they can get. The bad news is that we ask people like Mohammed to use premix instead of analog, because we run out of analog completely. There's no analog sometimes in Gaza. And so that we ask them to use premix. As a simple medical process, insulin is insulin. But of course, from the life point of view, it's a major differences. But still, that's what we did. And they work with the health clusters very well. And the WHO gave us NCD kits thanks to Slim. And the MOH, somehow we work together, but medicine remains major challenges. So that if we see the number of diabetes consultation by month from September, around 60,000, and it's now half of them in October, and gradually coming up. But still, it's simply because the hostility continues, so we cannot go back to the pre-war level yet. This is a shelter in Rafah. Fully packed. There's 30,000 people. Original plan for 2,000. And this is a tent near the shelter, 50,000 tent village. 50,000 people living here. And this is a medical point within the shelter. And this is a hepatitis A jaundice. It's a major problem because of hygiene situation. And usually medical points do not provide NCD, but because of this, we provide NCD. And doing something to make them feel there's something to enjoy. And this boy is very good. And then challenges. Of course, it's not easy at all. This is very complicated. We are not doing great job in terms of say like finding a new cases. We have no time to find the new case. We just maintain those who are living with the condition to continue. But the number of new cases is still low, trying to recover, but it's very difficult to do. At the end, but personally, it's important for us to remember we owe them a lot. We took in Gaza, in the northern part of Gaza City, there's a center called Rimal. That has the largest number of diabetes patients, which is around 5,500. And then we just checked with the Eritrean medical records what's happened to them. And the 2,000 of them, we couldn't find it. They might have gone to the other place where internet is not functioning, but probably we lost them as the treatment. Sorry for them. But the also important message that 3,500 of them became IDPs because Rimal Health Center is closed. But we found them almost 2,000 in Rafah, so they moved to Rafah, the southern part of Gaza, and they came to our health center to get the medicines. We have a record of this one. And the 1,200 went to the middle, a little bit further south from Gaza to get the medicines. So we have around 60% of them why they became IDPs. Whenever they find the health center, they come. So it's very important for us to respond to their needs. And then we found 12 went to West Bank, which is good. So I show you very inconvenient slides. This is a Gaza City. So we went there the end of last month, and this is entering the Gaza City. Sorry, Mohammed, but it's a really bad picture. And this is the inside Gaza City. It's all broken. And 300,000 people live, and this is also the inside Gaza City. Everything is broken. And then this is the famous Sifa Hospital. So is this a hope or there's no hope? There's a hope. So because these are health medical points, they opened recently. I went there, and then there's a shelter in the Gaza City, and this is a pharmacy with a limited amount of medicine. We brought a truck of medicines. And this physiotherapy room, because there's a physiotherapist, so they do it. And there are 2 doctors working there. And then there's one doctor's room, the other doctor's room in the same room. It's a classroom because of the shelter. And then these are the people who've been working since the start of the war, staying in Gaza. And then they're working with them. They have never eaten meat since October. They found the egg recently when I went there, but one egg cost $10. Now it's getting better, but still, within this, they are continue to working with this, and it's very important for us to continue to support them. As far as they are there, we can continue to provide the care. Thank you very much.
Thank you very much, Dr. Seta. So, a lot in that short presentation. Once again, I'm just reminded of the incredible importance of data, of registration of people with diabetes, and the fact that you've been able not only to quantify needs through the fact you have this quite advanced registration system in place, but you've been able to trace people, which is something that can make a critical difference for continuity of care for diabetes. Our third speaker is joining online. That's partly because we unintentionally organized the meeting during the WHO travel ban week, which means that WHO colleagues mostly can't join us here in person. We'd actually tried to avoid that week, but we somehow got confused. So Dr. Teresa Zachariah is a medical doctor and public health practitioner with over 20 years' experience responding to humanitarian and public health emergencies. She works as an incident manager with WHO at the headquarters, and particularly she has coordinated the incident management support teams for the humanitarian crisis in Israel and occupied Palestinian territory. And she is based in the Humanitarian Interventions FCV unit in the World Health Emergencies Program. So, Teresa, great that you can join us today. I just would like you to, once again, please share your perspectives on this question. And I just want to also recognize that, you've been coordinating the WHO response in both Ukraine and Gaza, very different challenges. I'd be interested to hear if there are some generalizable lessons you can draw out regarding diabetes and, and things that you would want us to think about earlier for the next response. Yes, over to you.
Thank you. I hope you're hearing me well and you're seeing the right screen with the presentation. Okay, so many thanks, Kiran, for the introduction. I just have 2 slides actually, and it's really for brainstorming with all of you. I know that the level of expertise and experience is extremely rich in the room, and it was a pleasure to listen to Dr. Seita just now, and I keep on missing to meet him in person actually up until now. So I am based on the request provided by Kiran, but also Sylvia and Anna. I tried to bring multiple experiences of just what happens in the first 30 days and how that impacts diabetes care overall. And my biggest question is always like, how much prepared can we be? Because it really forecasting correctly the impact of disasters is just not possible. And there are these 4 elements of what happens directly after a disaster that really shakes us all and basically unhinge our preparedness efforts very frequently, but also just keep on surprising us even with the best experience possible responding to all sorts of humanitarian catastrophes and public health emergencies. So just wanting to highlight here that I'm not saying that preparedness is not important, not at all. I think there are still a lot of elements. I think looking at preparedness in maybe more creative and innovative ways would be what is truly needed. As when something big hits, it's just extremely difficult to see where the situation would evolve, what parts of the societies governance, but also just law and order and physical and infrastructures we would need to cope with, manage in order to deliver all humanitarian assistance. And these big 4 items are always the ones that really test our ability to respond, our flexibility to respond, and really just to look at how much of what we had prepared in advance could be used. And forced displacement is major. When we have major shifts in population size and composition, area-based preparedness, even stockpiling of the essential supplies in different locations may be extremely compromised too, because no one can really anticipate in advance how much humanitarian displacement would change these dynamics, would just render all of the stocks that we have insufficient. But also, especially when these displacement occurs across borders, where there are significant language and cultural differences. The second one, of course, is the physical damages. And I took this photo from, it's actually a hospital in the US, in New York. And as you can see, even hospitals can suffer from damages from even, this obviously was not an intentional act. It's a flooding situation. But hospital preparedness will also be challenged to its core in dealing with this gravity of a situation. And the third one is infrastructure destructions. And the photo there is from Ukraine, destructions to the oil pipelines. Or as we are all struggling with in Gaza at the moment is very limited communications, no internet connections. And so all of the data, even if we were in position of these prior, become just very difficult to access, to update, and also to provide the best care that we can. Even trying to access warehouse logs, it becomes extremely difficult because the roads aren't accessible anymore. We don't have electricity, and communications are cut. And also, of course, there's the issue of violence, including targeted attacks against health. So the hospitals, the ambulances, the healthcare providers, and also the patients. And so these are four elements following acute events, sudden onset disaster, acute escalation of protracted emergencies that can really shake our preparedness level, but also really require us to continuously think of adjustments to be made. So perhaps that is actually a very critical component of preparedness investment. It's really just, how do we continuously adjust? And all of this is happening in changing landscapes because we have changes in health risks. We would normally see, in all cases, raise in trauma and casualties. So suddenly our public health situation analysis would highlight the trauma and casualties as the first public health risk, while in more peaceful time, or in the absence of escalation, NCD would come first. And so that also changes the perspective of how healthcare workers provide care, provide services, and also what platforms of service delivery are adapted to this to respond to these health risks. What's interesting in Ukraine, for example, we had trained and deployed a lot of emergency medical teams, the pre-hospital care, but none of them were really adapted for NCD care. And so that required a lot of change in mindset, in the training, but also in the medicines, the supplies that these teams had to bring with them. But, in the case of Gaza, with the collapse of infrastructure, how do we make sure that, the cold chain is maintained? How do we make sure that, insulins can be shipped in ready to use containers, refrigerated, energy independent, and so on and so forth? There's also prioritization of services that would happen most of the time. And when trauma becomes the dominant feature of health impact, then unfortunately, it is very likely that NCD care would be put at second line. When hospitals need to prioritize their services, they would need to then look at emergency services, operating theaters, but then those elective surgeries and less perceived less life-saving services would be put on the second line, and the consequences of these is extremely dire. I mean, Dr. Seita showed that there has not been new diabetes cases detected, and that is, I would, of course, it's multifactorial, but the fact that yes, some services are prioritized much more than others also contribute very much to that. And that is happening while people lived with increased stressors, physical, psychological, social, everything, and extreme living conditions. So, patients with diabetes who've managed to maintain, an adequate, healthy lifestyle prior to this acute escalation, won't be able to sustain that. And how much does that increase the risk of complications? And this would be beyond just diabetes, right? But all sorts of non-communicable diseases for which, living conditions and the complete state of well-being is required to manage these diseases. As I mentioned, the task shifting in the health workforce, perhaps this is an investment as well that we need to look at. How do we make sure that, all emergency pre-hospital medical services, emergency providers really are properly trained in detecting complications, especially to non-communicable diseases, administer emergency interventions on the spot. And then that platforms for service delivery. I think we have learned, and again, I think also highlighting the resilience of people, which sometimes perhaps is underestimated because we never knew that people would be reacting in such a way when disaster strikes. But in Ukraine, I think the very fast adaptation of these emergency medical teams and mobile health services was quite impressive. And year two, once the trauma cases, the casualties are much more managed and are much more anticipated as well. And then kicking in NCD services then becomes extremely important. But for that, then all of the responders really need additional training. Also taking into account because a lot of the NCD services are hospital based. While in case in those first 30 days, hospitals would be extremely compromised. And that is why we need to adapt also the platforms for service delivery and making sure that there's more outreach and making sure that then the non-specialists of the specialist doctors who are providing these outreach services are fully equipped as well with knowledge, experience, but also all of the supplies and the supporting environment to be able to provide proper diabetes and all other NCD cares. So all of these, this changing landscape amidst complex operations, and how can we make things better moving forward? I do believe that there are technologies that we could capitalize on much better. And these two are the ones that occurred to me while preparing for this presentation. But yeah, the use of drones because roads are damaged, right? Or the introduction of these solar-powered vaccine refrigerators as well that were made very much more accessible during COVID. And so how could these be repurposed, developed further to make sure that then diabetes kits, because I think perhaps even, there is a need for such, could be better prepared and be ready to be deployed. I think this is key. Deployment of human resources, deployment of, energy independent medical supplies and medicines are critical because again, in those first 30 days, we don't know what the true extent of the impact of that sudden onset or acute escalation would be. It is, as learning from the experience in Ukraine as well, and also in Gaza, because medical personnel on the ground would be equally impacted as the rest of the population. And so, how do we make sure that these temporary substitution capacities could be searched in the most innovative ways as well to again take into consideration all of the structural infrastructural constraints on the ground, to also give the time and the opportunity for then our healthcare provider colleagues on the ground who are impacted to also rest, recover to the extent possible, and then be able to come in and help again. So I think, I'm sure there are many other innovations that we could tap into, those that are already existing for vaccination or for disease outbreaks that could be leveraged. And I think massive training, definitely. My first experience working with SLIM properly was actually during the Ukraine response. And as someone who's really been looking at humanitarian emergencies in sub-Saharan Africa, it's true that there's less automatic thinking, or the perspective on NCD just needs to be also changed. So continuous advocacy is definitely needed. But then yes, make all of those technological advances, also research that is being done for disease outbreaks could also be leveraged for NCD and especially diabetes care. So I'll end here. Thank you very much, and I'm happy to join the rest of the discussion.
Thank you very much, Teresa. So, well, that was you said a great deal there. That was a very wide-ranging discussion. Thank you for also frankly sharing your thoughts. Particularly, I'd like to highlight that point that you made, that, in all honesty, that public health situation analyses will not tend to prioritize NCDs, including diabetes, in sudden onset crises. And I think it's a reminder that we have not yet really succeeded in changing the discourse, the narrative around NCDs. As Teresa mentioned, the perception remains that these are less life-saving services. And yet we know for type 1 diabetes, we're absolutely talking about life-saving in acute emergencies. So that narrative there, we've got a lot of work to do still to change that narrative. And for the point about automatic thinking about NCDs, we need to be automatically thinking about NCDs. And I think as Slim highlighted at the beginning, that point about recognizing the vulnerability of people with diabetes in sudden onset humanitarian crises when they require insulin for survival. I'd like to invite up Stefan now, the final speaker in this panel. Stéphane Besançon is a biologist and nutritionist with degrees in nutritional physiopathology and international development. He's the founder and CEO of Santé Diabète, which has set up numerous pilot schemes for the prevention and management of NCDs and especially diabetes in Africa. Amongst a number of different accreditations and affiliations, he is a member of the WHO Global Coordination Mechanism on NCDs and one of the 27 members of the WHO Civil Society Working Group on the third high-level meeting at the UN General Assembly on NCDs. So important to catch Stéphane while he's here for these 2 days if you want to influence that process. Stéphane, please come up and join us. I'd just like to say that from the perspective of someone who's seen both a sort of an international NGO and with also a very national feeling as well, based in Mali, I think you've navigated this NGO through the support it provides in complex humanitarian emergencies where access has been extremely challenging. I'd be grateful if you could say a few words about the practical considerations of providing complex care in these settings. Thank you.
Thank you to invite me to do this short presentation around the crisis in Mali. Started in 2012. The crisis is still in progress, so I will not give you a topic on 10 or 20 years of crisis, but just on the 30 days and to explain you how an NGO on the field, humanitarian NGO, can work very quickly on different sides to try to deliver the thing for the patient. So just I will start with just two slides on the context to just present you the Mali that you can see and the start and to better understand the start of the crisis in Mali. So Mali is a West African country. It's a very huge country in top of the left of the map. With just 22.5 million of inhabitants, it's a very, very poor country. So the health system and everything is at very, very poor resource. And despite this context, the prevalence of diabetes is up to 3%, and the prevalence of hypertension is around 20%. There is a high prevalence of sickle cell disease. So NCD is a real health priority in the country. So our topic today is a crisis. So what was the situation in Mali? The history started in March 2012 in the south, in the capital. There was a coup, the first one, because there was a lot now. The first coup in the capital and followed by an attack of the rebel group and terrorist group with AQMI and Islamic State. And in 2 weeks, the country got down and the country was cut, but totally cut. You have the red line, and it's a huge country, and the part cut by, from south and north is very huge. So the access of all the north region was totally impossible. So the consequence in the country for the health system, it was in 2 weeks, there is no more human resources in all the north region, no access to medicine and no possibility of measurement, laboratory, and other thing. And a big accepted the hospital of Timbuktu with a strong negotiation by MSF to keep the hospital in place. All the other health structure was not totally destroyed, but partially destroyed. With Santé Direct, we was on the field and we was here and we decided to start a very strong humanitarian response for diabetic patients. During many years, we have different phases. The first one that I will speak today, life-saving, is a beginning. And after we have a protracted phases, we improve the response, we improve the management, and the last, we participate to the reconstruction of the healthcare system. You can find all this response in this paper in Conflict and Health, but today I will just do 3 or 4 slides on the first phases, the life-saving phases, and the humanitarian action needed when you are in the country with conflict, war, group, rebel, terrorist, and you need to negotiate also. Because I will focus my topic on diabetes, but also on access, because I think when we are in humanitarian setting with a strong crisis, with war, the main thing is access. We need to have access to the area, access to the patient, access to test, not just of people, but also all supplying needed. And the third thing, everything that I spoke is 1 week on 10 days. It's very quick, that start, and you need negotiation, night and days. And the first thing was the mapping of the beneficiary need. And in our case, it's very important to have the mapping of the patient, where is the patient, and what is the need of the patient. Because if you want to supply, if you gain and you have access, you need to have a precise mapping, and in the case of diabetes, sometimes it's a problem. And in his introduction, Slim spoke about using the existing consultation mapping and thing, and I think it's very important. And in Mali, we had a lot of consultation before the crisis, and we use this consultation mapping, but also after with a local partner, international partner, because there was a lot of over NGO in the field. We organize a precise mapping because the patient move also between the different cities with the crisis to have a very strong mapping of the patient, and the mapping of the patient permits to have the need on insulin, anti-diabetic drugs, and other things, because we need to have a precise need to supply the good thing for the patient. So in practice, after that, very, very quickly, after 3 weeks, we start. First decision, we had 5-6 cases of type 1 in North region. We organized the evacuation of patients because with type 1 it was so complicated, there was almost nothing, the war was in progress. So we organized the evacuation of the patient from North region to the south, to Bamako, the capital, to continue normal care, to try to continue the normal care. And for the patient stay in the north area, we supply the patient association and different the group, and after they turn supplies to patient. And in 1 week, not 1 week, sorry, in 1 month, we arrived to identify 1,840 patients, and we start the supplies, insulin, syringes, anti-diabetic drugs, and other need. You can see in the region of Tombouctou, you have almost 1,000, region of Gao, 642 patients, and Kidal in the north, we have less patients. A lot of patients go in Algeria, 73 patients, and the last district before the south of the country, 111 patients. And that we start at the beginning of the crisis, but the crisis is so long, and we continue to supply almost everything until 2015. And in 2014, MSF and ICRC joined us on diabetes, because MSF was in the hospital of Tombouctou and ICRC in the hospital of Gao. But in 2014, MSF and ICRC joined us to supply also the diabetic drugs and the need for the patient. So it's a short presentation, and I have for today 3 key messages in a context, because very different context. My context here, it's war and it's chaotic situation with a health system almost destroyed. If you want to respond very quickly, we need 3 things. The first thing is to negotiate very, very quickly the access to the population and to the conflict zones. That it's essential. To arrive to carry out a mapping of patient location and their need, that also it's essential, because it's not the same things that provide metformin or provide insulin, and if you provide so much insulin and no need insulin, it's a problem. So the mapping is very, very important, and the patient move. I present the 30 days, but after patient in Timbuktu run to Gao because there was attack. So you need to have, we need to have this mapping also if the patient move to change the supply in the region. And the last one is to deploy very, very quickly the local logistic chain to supply the patient with the oral antidiabetics, insulin, and other necessary products to be sure that people have access. And like I said at the beginning, it's a life-saving phase, the first month or first 3 months. After, we can change, we can start to speak about quality of care, reconstruction. But for me, at the beginning, there was nothing. I think, Mohamed, you said that also. The necessary is to have access to insulin, to drugs, and after, we can see what we can do to improve step by step with the context. Thank you very much.
Can I invite all of the speakers from the panel to come and have a seat up on the stage? And Teresa, if you're hopefully still there online, that would be great. So, thank you. So, Stefan, thank you for that. Yeah, a great summary, a very practical example, and very impressive response in Mali. I think, as with the other speakers, you've highlighted for me the fact that whilst on the one hand you made very effective and successful efforts in the very early stage of the emergency to map, to understand the situation, to negotiate access and so forth. It was also what you had in place prior to the emergency that was critical. I think this echoes some of the points from Seta, but also Teresa's comments about the fact that it's very, very difficult to be absolutely prepared for sudden onset disasters, but we need to think about how to do this how to be adaptive and how the preparedness can be adaptive. And I'm also wondering if we have any academic colleagues in the room, because I think there's also a need for your engagement on this about how to make these anticipatory systems more adaptive, and is there a need for modeling in that? So we're going to open up the floor for discussion now. We have, I suppose, 10 minutes for discussion, which I realize is a limited time, but I think that the themes that we've talked about here will keep coming back in subsequent discussions. I'd just like to invite very quickly each of the speakers, given that you have heard your colleagues' comments, just if they would like to share a reaction about what they've heard. For example, particularly if you think, following these discussions, there's one thing I would like to emphasize for the next emergency response. So I think if, in turn, we can just invite the speakers in the same order that they spoke, just to pick up the mic and just share if they have a comment to start the discussion.
Well, thank you then. Well, I've got 2 comments, and of course, I'll start with the positive one here. Because I do agree with Stefan with, yes, we need to start working with mapping the services, the needs for the patients, because we need to ensure, again, equity. We need to ensure that it's not too much insulin or too little insulin, and that's extremely important. And my second point is to Dr. Saita, which is, again, insulin is insulin. Insulin is a life-saving medication. That's important. But when we talk about contexts, we talk about what has, for example, a specific system has built throughout years to support the insulin delivery and the types of insulin, types of insulin that are being delivered to the patient. So, if for example, in UNRWA, we know that in Gaza, it's been for years that they've been delivering insulin pens, basal bolus regimes for children under the age of 18. And it's been for years, but now during crises, we see this sudden change to pre-mixed insulin and very little education to how to switch from the regime that they've been used to for years to a regime that's completely different. And this means, again, more complications, more hypos, because if there's no food available, then if I take my pre-mixed insulin, this would mean that I'm more susceptible to hypoglycemia. And that's definitely something to take into consideration when we talk about education, we talk about the supplies themselves, we talk about equity, we talk about types, we talk about what is it that the patient need, and at the same time that we ensure that, yes, it's the premix is the type of insulin that is used in humanitarian crises, because yes, it would work all the time, insulin is insulin, but we have to think about how can we support the resilience of the community itself and ensure that they at least are not losing the momentum that they have been building in, again, building the quality of life that they try to get.
Thank you very much. I realize I passed one slide because my boss Anna said that I have only 8 minutes. So I was counting the minutes and finish it. So, but that's a summary one. But the one thing I want to highlight in the final slide is systems of response. It's important that we don't need to produce something ad hoc. It will fail. I think based on the system, we do maximum we can do. And so it's largely rely on the pre-war health systems capacity that define this one. Your comment fully agree. We had a heavy discussion, and there is a WhatsApp group of the mothers in Gaza, those who have the type 1 kids. They heavily attacked us. This is not the medicine. I said, no, this is the insulin. No, they said, no, this is not the insulin. It's kind of that kind of, and then and I asked Sylvia what to do and which dosage we should use. And we gave instruction to the doctors, but I know that the mothers are still not happy. I think that we really need. And my colleague Shadow will talk how difficult for us to buy analog insulin, not only the ordinary insulin.
Yeah, Teresa, please go ahead.
Oh, thank you. No, it was definitely a lot of learning for me from the other panelists. I mean, I'm not an expert in diabetes. I'm a public health person, so thank you for sharing all the knowledge as well. I wanted to reflect on what Mohammed said, the community and the peer support, and I think it's true that there's definitely a lot of scope as well to include. I mean, it's also the integration of diabetes care and CD care as well in all of the community engagement work that we do. And we've made lots of progress in community engagement for high threat pathogens, again, communicable diseases. We haven't invested that much in NCD care, in the diabetes care. So that's definitely an area that requires proper investment. And also because of the long-term nature of the care needed, that ownership by the community is truly needed. And just adding as well, I know that for the experience of Ukrainian refugees as well in Europe, the brand, the posology of all of the medicines that they received on European soil was also quite, according to them, challenging to accept. So echoing that as well. Lastly, on what Stefan mentioned, mapping the displacement is truly important, and also acknowledging that it's a very dynamic situation. People are displaced multiple times, and with every experience of displacement, their vulnerability increases. It's more likely that they would lose their medicines again, because as Mohammed said, you don't go to your fridge, you run away with your family. And so how do we also make our service delivery, the platforms for service provision, also as adapted as possible to these very complex dynamic of population displacement. Thank you, Kiran. Back to you.
No, my comment will be on the point of Mohamed and on this type of insulin and the change, because when I said my opinion and the need, after the reality on the field, you have budget and you have the capacity to buy very quickly think. When, for example, in the response on Mali, we have different need of insulin, different need of things, but we buy one insulin very quickly to be in capacity to deliver it. So your point is a real question, because after patients receive different form of insulin, no education, etc., etc. So this point it's a central and main point for the reflection, I think, because we need to deliver very quickly, but also to take the real need of the patient, and sometimes it's not easy because you have a question of budget and the rapidity to buy, because if you can buy this type of insulin in 2 days, you cannot wait 3 weeks or 4 weeks to buy another one, but for the patient, there is an impact. So it's, I think, very important question to discuss and to manage.
Thank you, Stefan. So we have a few minutes for questions. Anna, will you moderate the online questions, or is there anyone? Yeah, okay. And if you don't have time, if we don't have time for your question now, please hold on to it, because this session is the framing, the opening session. It's a little shorter than the others. We will have more time for discussion throughout the day. So first question.
Yeah.
So could you please just introduce yourself and then...
Okay, I'm a human rights lawyer from India who also works for MSF. Quite a contradiction, I have to say. But I just wanted to simply say this, that I worked on the Myanmar-India border, and I saw the difficulties on supply chain. And of course, NCDs were seen as luxury. So this kind of session which sensitizes stakeholders to respond to NCDs in emergency is really welcome. So I just had a point. Is there not a need, and I'm quite disturbed by, WHO's own position, where they say that, you have one standard for high-income countries, you have another standard for low and middle-income countries, even in emergencies. And what I wanted to respond to is this, can't humanitarian actors reform what they are buying? Why should we accept the premix from Novo as a donation? Why shouldn't we ask Novo to, give the right insulin that we need in humanitarian context? Why are we not making these demands of the big pharma companies, but also of WHO? And I just want to highlight a point that really disturbs me about the opening comment of WHO, engagement with private sector. Engagement with private sector goes only so far. We've seen this in the pandemic when we were asking for vaccines. You also have to hold the private sector accountable, and Novo and Sanofi and all of them accountable. So what's being done to diversify supplies of insulin? But among humanitarian aid actors, is there a conversation that we should be buying the analogs or the pens, and how are we going to reform the supply chain so that, the conversation that the mothers had on the WhatsApp group is not repeated in another humanitarian crisis. And I don't think so this issue is about human insulin versus analogs. The fact is the problem has been the same with human insulins and analogs. They've been too expensive. They've been supply, concentration in the hands of few pharma companies. And WHO has to confront this and start talking about it openly. So this is my comment to WHO, but also to all humanitarian actors. Are we having a conversation about what we are buying, and are we reforming that? So just on that.
So thank you for the question. I don't think it was directed to a particular panel member, but please say so if that's not the case. And I think that whilst a part of that question we'll be able to come back to in the insulin panel discussion, I just want to ask if there is someone from the audience, such as Helen or anyone else, who would like to say a comment to add to that.
If I may, Kiran.
So just...
Member states actually follow WHO guidelines. So, WHO is at the center of response to emergencies. and is actually laying out the NCD strategies for our country. So
That's fine. In fact, I was going to say that because Teresa, who's on the panel, probably it would be a bit unfair to put Teresa in that position because she's the World Health Emergency Programme. But actually, Slim, I think, is still online. And so, Slim, if you can hear that question, would you be happy to respond?
Indeed, and I raise my hand. I think I would like to clarify the formulation around private sector engagement and what does it entail. I think, as rightly pointed out, I think by the colleague in the room, I think we need to hold all actors accountable, and also, I mean, ourselves about how we what are the guidance that we are making for the countries. First of all, I think what we are trying to envisage is really to address all the options based on the best evidence about what works and the efficacy. And I think WHO have issued different guidelines. We are currently updating our guidelines for type 1 and type 2 diabetes, including, I mean, some of the specific question related to access and the treatment and the management of diabetes in humanitarian setting. And accordingly, as the discussion evolved with also the new therapies, we have a lot of pressure at the moment, as you know, on the analogs, not only for their indication for diabetes, but also for obesity management. I think we are addressing this at the moment, reviewing the evidence, also trying to understand in a fast evolving market how WHO can better adapt its recommendation. On the private sector engagement, both in humanitarian settings, I have been, I mean, for the last, I would say 15 to 20 years in discussion with many of the private sector company. And of course, we understand that there is this oligo monopoly specifically on insulin. I mean, this was something that I raised in the insulin report that I was referring to. We have actually mentioned the bottlenecks, and I think we are not shying away from understanding that there is difficulties and challenges, and the private sector have its own responsibility also to address this. The way we have organized it recently is what we call the private sector dialogue, where we are trying to frame some of the challenges and also trying to
Recording in progress.
a commitment for us to be able to maintain that positive pressure and the dialogue to reduce the price of both, I mean, the insulin, the originator, but also the analog discussion. Also in that bundling, because more and more diagnostic, also an in vitro diagnostic list has been also something that we have been focusing on, is how we try to make specific ask to the private sector. So it's not something that we are, I would say, in a very condescendent approach to the private sector or only contributors. I think what we are saying is that this is the situation. How can we solve it? Also tapping into the resources of all stakeholders. I think the private sector dialogue is a tough one, but I think it's a constructive one that's built on long term. And we need actually to continue to explore all the options, both on analogs and even on the essential drug list that many countries do not have. I think there is also the usual argument is that even if the drugs were made cheaper or the cheapest of the countries are not still prioritizing it. And I think we used to say, okay, this is our job in WHO to also support countries in prioritizing the NCD and diabetes within the agenda, and also making sure that in the selection of drugs, they have, I mean, that panoply, and some countries are already doing it. If you look at the situation even in Gaza, I mean, there was a mix of approaches on both trying to maintain core essential drugs, but also looking at analogs for a subset of the population, specifically children, with challenges, of course, to be able to provide this on a timely basis. Over to you.
Thank you, Slim. We just have time. We just have time for probably one more comment. Well, maybe maximum two. Helen, and Helen, go ahead. And then Anna, is that an online comment or an online question? So we'll see if, and Lars, we'll try and take those three comments and stop there. Just make it concise, and please say which panelist the question's for, if it is for one panelist.
Well, maybe for CITA, because I think in reflection for this meeting, MSF, we've looked a little bit around our in-country e-PrEP, and we realise there's work to be done there. It's not consistent that diabetes meds are included. But again, if we look in the different regions where crises are occurring, do we need to be more flexible about our in-country e-PrEP so it reflects what people living with diabetes are actually using. And I'm going to come back to Lena's point, hold the companies accountable to, in their inverted commas, donations, provide something that reflects what is being used in those settings, whilst we advocate for more patient-centered, more people-centered, friendly devices, types of insulin to be used more globally. Because I think the situation, Saito, you described, it's fantastic. Thank you for that presentation. But it's not just the type of insulin, it's going from pens back to vials and syringes, which for me actually blows my mind in that situation, getting a kid or mother of a kid to do that totally blows my mind. So these companies are making huge profits on GLP-1s. Can we hold them accountable to provide what reflects what's being used in different settings and plan that in our in-country e-prep? So Saito, I don't know if that's something maybe for you.
Should we take the other comments? So is that what you're saying, Seti? Yeah, maybe in the interest of time, Anna, could you share your question, and then Lars? Yeah. Yeah.
Yeah. Hi, Lars from the Danish Red Cross. I was wondering to what extent and how could we maybe also talk about non-medical interventions in these first 30 days? So talking about maybe radical changes in diet, is that possible? A very low carb diet to reduce the need for insulin, to reduce the negative impacts of switching insulin to other types of insulin. Is this something that you have considered in your responses, and is this something that you have also heard from your colleagues in your Taiwan diabetes community? Yeah.
Mohammed, do you want to take that one, or maybe Stefan, and then Anna, the last question? Yeah.
Yeah, this is for Stefan. You clearly mentioned good approaches in such complex operations. In your experience, how do you maneuver your ways? If you could give more education on the methods applied in negotiating access and conflicting parties. Big question.
So just short responses from the panelists. Seta, do you want to start, and then, yeah.
For the insulin business and which medicine to use, I think we need to have a systems. National system is everything. Where there's no national system, nothing goes well. I think that's the important part. Either they use pens or analog, for example. Say like in Syria, we use mixed drug, human insulin. So it depends on the system. But one thing in this system, one thing I want to highlight is Silva is a fantastic doctor. But there's not always good doctors in the market. Private doctors give us more headache than the good. And then what I learned in Gaza is there are so many uncontrolled use of diabetes medicine in the market. And they came to us to get the medicine. Then we say, what is this? This is not even WHO essential medicine. This is why you're using this. That kind of thing. So I think in the system development, it's very important to engage private professionals to use this one. And for the insulin companies, we ask donations. All of them, all the three major, and Shada, can I talk or not? It's okay, because she has a presentation. So that the three major donations, and I can tell you, one of them declined because it's UNRWA. Because of UNRWA, they say no. But they say that we can give you through the different channel, but not direct to you, because of the government where they are working. So that's also, very sad story we face. But we ask all of them. Yeah?
Yeah. Yes, again, a very sad story. Now, for the non-medical aspect of it, yes. Yes, absolutely. People with diabetes always talk about this. But again, when humanitarian crises occur, the immediate response would be, again, depending on the context, what's available in cheap prices for people to be given. So, for example, in the context of Gaza, we're not able to just, for example, provide protein supplies. It was always bread. It was always pasta. Yeah, so it's always carbohydrate based, and that made it extremely hard for people with diabetes to manage their conditions. And again, we changed types of insulin, changed food, to change their routine. And I personally know someone who was at, on average, around 35 units of insulin a day, and total daily insulin, and they went from 35 to 80 just because of, again, less food, but it's just more carbohydrates. That's it. So that is definitely a problem. We discuss it all the time. We talk about possible solutions, and again, in times of crises like this, it's really hard for those patients to be able to get access to vegetables or fruits or any source of other any other source of food. So it's hard, and again, it requires a system. That's what I mentioned in the beginning. I mentioned the health system. So this also includes all determinants of health. What determines their life? How can we all in the community or in the private sector, in the public sector, all actors, how can we all act to ensure that there is a system that is efficient and adaptable to what's going on, and can educate and teach patients on how can they proceed with it? Yes, thank you.
I'm not sure I will answer totally to the question, but no, the question of access and negotiation, maybe I will say that, because it's a discussion now with UNRWA, and the discussion of neutrality is on the table every time. It's to negotiate access, is to not be part in the conflict and explain you are here for the population. That it's important with the mapping. And no, it's very strange, because we every time we discuss that we need to explain to the international community, UN agency, during a crisis, the necessity, you say that, Kiran, to explain the emergency with diabetes and CD, but it's the same with the group on the terrorist or rebel group, to explain that we need an access very quickly because there is emergency need. And people say sometimes, oh, but we have time. No, with insulin, we have no time. And to re-explain why, but with diabetes, the good thing is that there is a high prevalence of diabetes. So you can have patients almost in every group of population and group in action. So people can understand that it's an emergency. But I think this point is important. I think to also re-explain at all the player, including sometimes military guy, we say we block this area during 3 weeks or 4 weeks, but people cannot wait if they need insulin 3 weeks or 4 weeks. So, but after it's a work of negotiation. There is no rules. It's just to try to do the best to give access to the population very quickly. And the point discussed now weeks after weeks is the neutrality, and to explain that we are humanitarian and not part in the conflict, and you are here for the population, and to try to continue to explain. But it's, I think, more and more difficult.
Thank you, Stefan. Very quick comment for Tom, last comment for this session.
Hi, I'm Tom Ellman from MSF. In fact, I think just as we transition to the other sessions, the point that Seita made around how we engage with the private sector, and linked to that, how we ensure correct, simple care rather than complex misuse of multiple different medications, I think is a really important question for us, dealing with diabetes in the broader humanitarian context of absence in low-income settings. And I think the question that perhaps could be posed in emergencies is, are we using the opportunity that they can represent to bring about improvements in care and better engagement with the private sector? And I think we've seen in COVID many examples where the opportunity and the absolute necessity of simplification of care and decentralization of care that COVID brought to populations, including self-management and self-diagnosis of many diseases. I think there are lessons that we could draw from that and apply in emergencies in diabetes. Thanks.
Yeah, thank you, Tom. And that is certainly a point that we will come back to, the opportunity that emergencies represent to build resilience of health systems and also more sustainable models of care. we need to wrap up this session. I mean, that's been an excellent starting session because on the one hand, this has highlighted a few specific issues around the first 30 days, including negotiating access, rapid mapping of people and needs, the need for rapid insulin distribution, and of course the need to look after our staff the healthcare workers in these first stages. But this session has also highlighted some transversal elements that will be relevant throughout these 2 days. And just to name a couple of these, the importance of strengthening health systems, and particularly on data, on health information systems and registration of patients before crisis. The idea of a minimum service package, which must include diabetes medications. And as Teresa mentioned, does it actually need to include cold chain as part of the package? The importance of people living with diabetes to define their needs in emergencies, or to help with the definition of needs in emergencies, and in particular, the types of insulin that are needed and are most appropriate. And then a final point that, as Teresa mentioned, I think is about the narrative around diabetes. Is it a chronic condition? Is providing care for diabetes life-saving or not? And that's a challenge around the narrative and how this feeds into policy, but also how it feeds into financing. So all 4 of those themes are actually the themes of the workshops that will be happening tomorrow. So I hope that will give us a chance to go really into some more detail on some of those aspects. It remains for me to thank our 4 panelists for their excellent contributions to get this meeting started, and to apologize for being a little bit late. Let's regroup at 11:10. Is that okay, Sylvia? So that means a 20-minute coffee break, 11:10. Thank you very much.
Tu es jolie, tu es gentille, je t'aime bien, tu es formidable.